Greetings to all. Angioplasty is a very common procedure nowadays. So the angioplasty is otherwise called as percutaneous transcoronal coronary angioplasty. In short, we call this PTCA. Basically, before angioplasty, the patients would have undergone angiogram test, which is basically a test to identify the blockage in the blood vessels of the heart. We all have 3 blood vessels supplying the heart. Angiogram is done initially to find out the percentage of blocks and distribution of blockages. And if the blockage is more than 70% in area, then that blockage cannot be treated with medications. And all blockages less than 70% can be treated with medications. And an angioplasty will be needed for a patient with a blockage more than 70% of block. In angioplasty, the patient is typically admitted on the day of the procedure. For example, in the morning 8:00 a.m. And then the procedure is done between 10 o'clock to 12 o'clock, depending upon the availability of the cath lab and other situation. And typically, a straightforward angioplasty with a single blockages takes 40 minutes to 60 minutes to be completed. In angioplasty, is done through a keyhole PR. It's always called as a keyhole surgical procedure. Basically, we call this interventional procedure. It can be done through 2 sites. One is through the right wrist Y, which we call the radial artery. So yes, a small plastic tube is kept in the radial artery on the right wrist in the cath lab. And through the tube, we can introduce a catheter which goes into the blood vessel origin. And through that tube we call catheter, your wire is passed across the lesion, and then a balloon goes railroading through the wire which goes near the blockage, and it is inflated from outside. So this is the first step where the blockage is treated with a balloon. Then we have stent, which is called the coronary stent. We call blood-coated or drug-eluting stents. It's Li mesh-like small 80 microns or 60 microns in pH thickness. So it's a very thin mesh-like device. It is mounted on a balloon. So it is shrunk on a balloon, and when it goes near, positioned across the lesion, the balloon is inflated and the stent gets inflated and gets attached to the blood vessels. So it, like I said, it is only 60 to 80 microns in thickness. So it's a very thin device. And after the implantation, the balloon, the wire, the catheter, everything is taken out of the system. And a coronary stent remains inside the blood vessel for life. The second part is sometimes we have to do a very advanced and a complex angioplasty. In that case, we have to go through the right groin. Basically, there is an artery called femoral artery where we place bigger diameter tubes, catheters for an complex angioplasty. The complex angioplasty patients who get blockages after the bypass surgery, patients who have not only cholesterol deposition, a lot of calcified blockages where the calcium deposits over the cholesterol blockage. And calcium is a very hard substance, so we cannot expand the stent when there is a lot of calcium. In that case, we do specialized procedures. There are 4 types of procedures. One is a rotational atherectomy, where there is a diamond burr which goes and rotates inside the blood vessel 180 times, and it cuts the calcium into very small pieces, like less than 8 microns, less than the size of our red blood cells. So then we do the balloon and then the stenting. The other device which has come in the last 1 year, which we use a lot nowadays, is orbital atherectomy. It is a orbiting device. So just like Earth rotates on its axis and also rotates around the sun, it has 2 rotations, and it goes inside the blood vessel and rotates 80 RPM per minute. So here the calcium is again cut into small pieces, but it is a bigger device where you can cut even the deep calcium. So the other device is called intravascular lithotripsy, where the lithotripsy is a shock wave which emits shock waves and can break the calcium. So these are the 3 important devices which we are using nowadays for the calcified blockages. And there is a specific artery lesion called chronic total occlusion, where the patient develops slowly over a period of time 100% occlusion. These blockers are very hard. It is very difficult to penetrate and pass the wire across the lesion. Here we use a lot of dedicated CTO wires and balloons where stiff wires are used. Another blockage is crossed and then the stent is implanted. And there are other complex lesions called bifurcation lesions, where the blockage is present not only in the main vessel and across the branch. And if the branch is bigger, we have to implant 2 stents across both the blockages. And we have to crush one of these stents to make sure the flow is maintained. So these are the very complex and advanced lesions where we use intracoronary imaging, where we pass a catheter like intravascular ultrasound or optical coherence in tomography OCT catheters, which practically take an image of inside of the blood vessel and then gives us the information what are the blockages made up of. So this is called precision angioplasty. where we can implant the stent and make sure the stent is well opposed to the blood vessels of the heart. So these precision angioplasties and complex angioplasties avoid a surgery to the patient, but still in certain nature of lesions, we still need bypass surgery. So bypass surgery is a very important component of the treatment. By doing this precision angioplasties, we can avoid the restenosis. Basically, we should also need to know about what is the side effects of the stents. Stents practically have a 2 to 4% restenosis rates. Basically, when you implant a stent for 100 people, 2 or 4% of the patients can develop slowly growing lesions inside the blood vessel and cause again a blockage. This is called restenosis, but these blockages are slowly developing. This will not cause any heart acute situation. They can be managed again with a special procedure called red-coated balloon implantation. So these are the things we should know about practically about the angioplasties. Thank you.